Hello, everyone, and welcome to the Down Syndrome Center podcast. As always, I'm your host, Dr. Kishore Velody, and today's topic is actually one that you have suggested, and that's why I always end every podcast with send me any questions that you may have, because I do truly listen to them, and then we try to find experts in the field to be able to answer your questions. And before we get into that specific question, I want to go ahead and have our speaker introduce herself. Dr. Koehler, you're with the Children's Mercy Hospital in Kansas City. Tell us a little bit more about who you are, your background, what you do, things like that.
My name's Dr. Ricki Koehler. I grew up here in Kansas City and I did my orthopedic surgery residency training at Boston at Boston University. Went to Boston Children's, worked there, and then I ended up doing a fellowship in pediatric orthopedics at Texas Scottish Rite in Dallas. And now, as Kishore mentioned, I'm working at Children's Mercy here, and I'm thrilled to be back at home.
I love that. I love that. And the way I actually, we've never met in person before, but the way that I came across your name was actually I was doing a literature search on hip issues in Down syndrome. And sure enough, in 2024, you and a group of colleagues wrote a really expansive look at all of the review of the literature that's been done up to this point and did a meta-analysis, we call it in the medical field, looking at hip issues and Down syndrome. And it was really comprehensive. And I thought, well, who better to answer this question that came from this family? And essentially, the question was really around looking at hips in people with Down syndrome. We certainly see a lot of hip issues, but what this family member wanted to know was really for us to be able to talk about what are some of those common hip issues, what are some ways that we can help prevent them, perhaps and perhaps downstream issues that may happen if we don't correct them in time. A lot of really great questions. So before I get too far into those questions, why don't you, if you don't mind, just share a little bit about what are some of the common hip issues that you see in Down syndrome, like why do we see them?
So that paper was brought about when I was training my third year. I had a couple of families come in with their children with Down syndrome, and they were concerned about changes in the way that they were walking. They said they weren't walking as much. They were wanting to sit down more. They were having real difficulty with their gait, and we got a pelvis x-ray. And unfortunately, in both those kids sequentially on the same day in clinic, they were both about 13, 14 years old. They had dislocated hips.
Hmm.
And so, in general, when you think about hip dysplasia, children with Down syndrome are not as common as other typically developing children. We think of two different branches: developmental hip dysplasia, where a person has a typically developing pelvis, there are no morphological changes. And then we have like children with cerebral palsy, where they have a neuromuscular hip dysplasia, where it's a muscular imbalance. And over time, that changes the pelvis. Children with Down syndrome, their form of hip dysplasia doesn't really match into either of those categories super well because children with Down syndrome, their actual shape of their pelvis is a lot different. So it's almost like a pelvis, like you take a regular pelvis radiograph and you clicked it and you dragged it this way. It's a lot wider.
Hmm.
The anatomy of the pelvis is a lot different. So you think of a cup and a socket as the pelvis. So the orientation of that socket in space is a lot different. So usually the pelvis is sitting kind of like this. And then children with Down syndrome, that cup portion of that socket actually faces a little bit more backwards.
I see.
And they also, the surface area of the cup itself usually is a little bit smaller.
That's
So a
interesting.
lot of the issues related to children with Down syndrome kind of come from the anatomical differences. They can certainly have some soft tissue differences, but a lot of it is actually the bony anatomy of the pelvis that can kind of give us some trouble.
That's really,
Um,
yeah.
Yeah,
For those who, we're a audio podcast. So essentially what you're saying is like the way that the hip is formed. When you say pelvis and hip, it's the same. Is it you mean the same thing? Okay. So the way that the hip is formed, even before they're born, is already kind of a setup, perhaps for later hip issues, potentially for people with Down syndrome.
that is correct.
Okay.
In actually the 1950s and 60s, when they were first coming out with karyotyping to figure out the differences in the chromosomes in children with Down syndrome, they were actually screening Down syndrome hips with ultrasound, kind of like how they measure, the head
Yeah.
circumference, how they measure the size of the abdomen. They would actually see the anatomical differences in the pelvis and know that that may not be a typically developing pelvis. And that was one of the ways that they considered a child maybe having Down syndrome.
Interesting. Yeah, and definitely what you were describing in terms of what led you to do that paper is something that those of us who work in this field, working with people with Down syndrome, we see so frequently where you would think that something like a hip dislocation would be really, really painful, and yet while these children were very much, I'm sure, experiencing some pain, the way that they're able to just kind of limp essentially, but not really have severe manifestations of pain is so fascinating to me. And we see that for kids with Down syndrome who have appendicitis or other painful things where they just don't necessarily on the outside show that pain expect that we would expect. And I guess what this person, this listener was wondering about too, is that if there is like a delay in perhaps a diagnosis of a hip dislocation related to the way that the hip is formed or dysplasia, as we talk in medical terms, what are some of the complications of not catching it early, potentially?
So unfortunately, when you get to the dislocation stage, so there's different people with Down syndrome, they usually have a very common trajectory. So when they're born, they don't typically have hip dysplasia.
Mhm.
They can have run-of-the-mill developmental hip dysplasia like other people, which is technically treated in a harness when they're a baby. So it is important, just like anybody else, to have talk to your doctor about if you've had a history of hip dysplasia, all that stuff. That's all still very important.
Mhm.
But usually children with hip dysplasia that have Down syndrome, normally what happens is around the ages from like 2 to 7 or 8, they will do something called habitually dislocating.
Mhm.
So they can actually pop their hip in and out. And, usually that's something that the parents notice. So they'll be like, Jimmy will be sitting on the couch, and then all of a sudden I'll hear a bang and his hip will kind of move weird, and then he'll stop doing it. They first will habitually dislocate it. Then it actually starts persistently subluxating, and then eventually it can become a fixed dislocation. So that usually
Mhm.
happens when you're older. And we have data that that can actually happen well into your adult years, like 20 or 30. Children with Down syndrome, as they grow into adults, I'm a pediatric orthopedic surgeon, so I don't do this surgery as much, but they do also get a fair amount of arthritis
I see.
because that. And arthritis is when your cartilage gets worn away in your hip socket. Once that happens, really the only thing that can be done is a hip replacement, which is highly successful in people with Down syndrome. So I would not say, oh, because they have the Down syndrome, maybe we shouldn't do a hip replacement. No, because there's lots of good data that that actually really improves their quality of life. From an orthopedic standpoint, the way that we treat it depends on the skeletal maturity level of the pelvis. So, if your child has a very immature pelvis, they're very young and they're habitually dislocating, we might consider doing a closed reduction and casting them for a little while or putting them in a hip abduction brace. But like I said, the treatment sort of depends on what the pelvis looks like because not all of them are quite the same and what age your child is.
And as you were describing the child who can kind of pop their hip in and out, I'm thinking of several patients that I've seen over the years where they'll do that, and a lot of times it's to annoy their parent that's in the room. They
Yeah.
like to make that snapping
Uh-huh.
sound, and so I've had a few children where they've tried to do like a procedure even as they get into their later years, into their teen years, and they try to stabilize that hip surgically, but then over
Mhm.
time the kids are just able to somehow start popping it out again. Is that an issue that is specific maybe to the kids I saw, or is that something that you see in orthopedics where it doesn't necessarily work as effectively as you would hope?
Well, in general, like you
Yeah.
mentioned, how kids with Down syndrome, they don't feel pain as
Mm.
similar as other people. So there's a lot of stuff that we have to do post-operatively to change our protocols because of that. We might cast them a little bit longer. We might brace them a little bit longer because they have a tendency of, kind of, even though they recently had a surgery, try to get up and walk on it right away, for example, something like that. So you got to slow them down a little bit more.
Hmm.
There is a decently high complication rate in operating on children with Down syndrome. Like for example, you just also got to make sure that their neck's okay before you decide to operate on them because the anesthesia, they manipulate the head a lot with the anesthesia, so you have to make sure that that's okay. But yeah, there is a decently high complication rate depending on the procedure that you do. But in general, a lot of times they are highly successful.
Okay.
When you take that pelvis that's shaped and facing a little bit backwards and you redirect it with an osteotomy, a lot of times that really helps. And then a lot of times, what people will do is they will tighten the capsule up with a surgery and then do any combination of like a soft tissue procedure. And that will definitively fix the hip.
That's great. And one of the things that this listener asked was about prevention. Like, is there a way to, if we know that these issues are more potentially more likely in somebody with Down syndrome, is there a way to prevent it? Or talking about avoiding certain positions like swaddling and things that we know that can potentially lead to other hip issues in people in general, in babies in general. Should they be thinking about avoiding swaddling or certain infant chairs, carriers, bumbo chairs, things like that?
So in general, with developmental hip dysplasia that's not related to Down syndrome, it's really good not to swaddle your child with their legs straight. So let their legs be free, let them fall out to the side. Um, that's just kind of general developmental hip dysplasia principles. In children with Down syndrome, what I would say is instead of really preventing something, what we should probably consider doing is screening. So getting a pelvis x-ray every 1 to 2 years in the clinic, um, to make sure that they're not persistently subluxating or that something's going on, because a lot of the data shows that unfortunately the physical exam doesn't necessarily correlate with the severity of the radiological differences that we see in the pelvis.
Hmm.
So rather than like trying to prevent them to do something as they're getting older, I wouldn't try to prevent their range of motion or walking or anything like that. But one of the questions that is really big is, should we be screening these hips much to the same way that we do children with cerebral palsy, who have a very, very high rate, depending on their neurological difference, of having hip difficulties? So that's one of the things that we're kind of working on as a country.
Yeah. Oh, that's really interesting because I know like in our current healthcare guidelines as they're written, we don't really have much in terms of what to do with the hip. So that is a really interesting thought process in terms of should we be considering more screening type imaging for hip issues in people with Down syndrome. That's yeah. The other part of the question, and I have to claim full ignorance. I'm not familiar with this procedure myself, but this listener had asked about something called the Sherrard procedure. Is this something that would be helpful in Down syndrome? Are you familiar with that, Dr. Kaler, at all?
So that's one of the soft tissue procedures that can be done if they specifically have a type of weakness. But typically, most of the differences in children with Down syndrome are not only related to the soft tissue differences, but rather the bony differences in the pelvis and the hip itself. So, like, I was mentioning the difference in the orientation of the cup. Also, on the femur side, their neck angles tend to be higher as well. So like one of the other things that we consider doing is actually cutting the femur and moving it down like this so that it's reoriented more towards the socket. So a
Okay.
lot of children with Down syndrome, they don't benefit just from soft tissue procedures alone. A lot of times you end up having to do something bony like a triple pelvic osteotomy if their skeleton is not mature, or something like a periacetabular osteotomy in an adolescent that has a more mature pelvis. And then the femur procedure that I mentioned is the acronym is a VDRO, or a varus derotational osteotomy, and that knocks the neck angle down to help reorient that femur so that it's more directed at the socket.
Wow. So obviously, as a pediatric orthopedic doctor, these are things that you do frequently and you're familiar with frequently. But I'm trying to think in terms of like recovery after are these long recoveries after it seems like
Yes, they
major
usually
procedures to me.
yeah, usually the kids are in a spica cast, which is
Okay.
like a lower half of a body cast, from anywhere from about 6 weeks to 3 months.
Wow.
And
Wow.
it's quite a lot of parents have a lot of anxiety about being in that cast, but the children actually tolerate them extremely well. Like to the point where we have to try to get them to stop climbing trees in the cast. Like they do, children can tolerate casts a lot better than adults do, but I think adults sort of imagine themselves in that cast and then they're like, oh my goodness. But children do very well.
Well, thank you. This has been a really helpful podcast for me because even doing this work for so long now, we really don't talk very much about the specifics of the hip when it comes to Down syndrome. And the way you've described it today, it really does hit home this idea that the way that the anatomy is, even right from the start, is almost a setup for potentially these issues with the hips. And perhaps we should be surprised that we don't see more hip issues than we do based on how you're describing it. Am I hitting that right?
Yeah, I
Yeah.
mean, a lot of the reviews say there's anywhere from about a 4% to 28%
Wow.
prevalence of hip problems in people with Down syndrome. So, it is a decently large portion of the Down syndrome population that has problems with their hips at some point in their life, whether they're an adult and they end up getting osteoarthritis and needing a hip replacement. Now you have to be careful because as the general population ages, a lot of us also have radiological differences in our pelvis. So it gets a little tricky there, like, oh, compared to the regular population, how
Yeah.
much is like that? But there is a decently large amount of hip dysplasia in people with Down syndrome. And it's one of those things that we always need to think about and that we should potentially be screening or surveillance of patients for it.
And do we think in terms of that arthritis, as our friends with Down syndrome age, the chances of things like obesity go up, and are there any other like medical things that we could be doing to help maybe reduce their risk of having arthritis as they get older, or is it not known?
Managing weight is
Yeah.
extremely important because with every pound that you add, the amount of force that you need just to move is a lot higher. And so managing weight helps arthritis quite a lot, actually.
Okay. Yeah. Great. Well, thank you so much for joining us on the podcast. Ricki, are there any things that you wanted to leave our listeners with, or any topics that we didn't discuss that you wanted to make sure we hit on this podcast today?
No, I think we hit all the highlights. Like I said, it's a different beast. It's not just like developmental hip dysplasia. So a lot of what listeners may read out there
Mm.
may or may not apply to their child because of just the differences in this situation.
Yeah, wonderful. And I think that really does highlight for all of our listeners, really. And the reason why we do this podcast is that we know that for many topics, including hips, as we've learned today, it really does require some expertise and understanding of the differences between somebody who has Down syndrome and somebody who doesn't in terms of the approach and the risk for certain things. And so glad to be able to have you on this podcast today, Dr. Kaler, to answer this question. So thanks again.
No problem. And if anybody has any other questions, like the specific listener wants to hear more about it, you can give them my email. I'm really happy to answer.
Well, I think we'll leave it at they can email me and then I can send it to you because otherwise we've had over a quarter of a million downloads at this point. I don't know that you want that many emails coming in,
I
but to
really
our
don't
listeners,
mind.
wonderful.
I give my number out to my patients and all
That's
that. So
wonderful. That's wonderful.
I know.
Well, to our listeners, as you know, and as we're just joking about, you can always reach out to us here at Down Syndrome Center at chp.edu. And we are always glad to take your questions like we did this time and find experts in the field to be able to help answer those questions. And if you want to join us in the work that we do here at the center, including this podcast, go to givetochildrens.org/Down Syndrome Center. But until next time, bye bye.